Hi, so let's discuss today about thyrotoxicosis. So, what do you mean by thyrotoxicosis? What are the complaints the patient comes to you? So, actually, we saw a case in surgery. Okay, a 30-year-old female came to the OPD with this sweating and palpitations. She is hearing palpitations. It seems she is hearing her own heartbeat, and her eyes are eyes with fixed gaze. Fixed gaze means there are still eyes present, which is characteristic Stelvag sign in case of thyrotoxicosis. So, and diarrhea is present in this patient. She came with this complaints to the OPD. So, what do you suspect? So, obviously, it is thyrotoxicosis. So, what are the clinical features of thyrotoxicosis? So, what is primary thyrotoxicosis, what is secondary thyrotoxicosis, and how do you manage this case if you are the professor there? Okay, so let's discuss. You are the PG there, okay, senior PG. So coming to clinical features. So clinical features, before that, before coming to clinical features, what is the etiology? So you say TSH, T3 and T4, no? So HPO axis, we know already. TSH, TRH from the hypothalamus, TSH from the pituitary, and this TSH will act on thyroid to produce T3 and T4, right? So, and we know already how this will be. First step is organification. First iodine should enter, okay, into the follicular cells. So iodine will be converted into iodide will be converted into I minus. This is first step, organification, and tyrosine residues, it will get attached, and MIT DIT formation will occur to the help of thyroxine peroxidase enzyme, and we'll have DIT, and if these two get combined, we'll have T3, and if two molecules of DIT get combined, then we will get T4. Like this it will happen. We know already these all things. We have cuboidal epithelium in the follicular cells, and whenever if there is any active gland is present, then there will be resorption of the colloid, and our cuboid will convert it into columnar, and in these cells the iodine trapping and everything will happen. Iodine trapping, organification, and we have tyrosine residues in with the action of thyroxine peroxidase, and they will get combined into iodine in 3' and 5' positions to form MIT and DIT, and these gets combined to form T3 and T4. We all know this about, and we already know about HPO axis, and this TSH and T3 T4. Okay, so what will happen in thyrotoxicosis? So these levels will be raised. T3 and T4 levels will be raised. So we'll see this TSH level will be decreased. If there is any rise in TSH levels, it is secondary thyrotoxicosis. Means secondary thyrotoxicosis is problem within the pituitary gland, not with here in the thyroid gland. So we should rule out first whether it is any primary or secondary, if there is any problem in the gland or problem in pituitary. So so coming to, this is the etiology, and we briefly discussed how the synthesis of the hormones are means T3 T4 are occurring, and we had already saw what will happen like that. So coming to the clinical features. So clinical features, generally the patient will be presenting to us with weight loss. He will come with weight loss, increased appetite, normal or increased appetite, heat intolerance. Heat intolerance means they will say how much cold it is, also they will say on AC, like that. I am feeling so hot, like that they will say, and they will have fatigue. fatigue and bruit will be seen. Fatigue and bruit can be felt on auscultation. Okay. Goiter may be present. Patient may come with enlarged thyroid gland. Okay. Single or multiple nodules in our thyroid gland, which is a head shaped gland, we may find the nodules, right? So the patient may come with multiple nodules. Okay. Then in GIT complaints we'll have, already we had discussed in the case also, the patient came with diarrhea. Sometimes it is diarrhea, sometimes it is constipation. So very few cases there may be constipation, but mostly diarrhea will be present. Okay. In constipation mostly we will see in hypothyroidism. Mainly BMR is rising, no? So increased metabolism, increased gut peristalsis, so increased diarrhea will be seen, increased motion will be seen. So anorexia, not feeling to eat, or vomitings will be seen. In serious complaints, already in this patient we saw palpitations are seen. So there may be palpitations, tachycardia, atrial fibrillations, so and high cardiac output, sometimes angina, exertional pain. So coming to respiratory systems, in respiratory we will see asthma. Patient may complain with the asthma. Patient may present with asthma, dyspnea on exertion. Okay, already we had discussed angina, chest pain on exertion, and here dyspnea on exertion. Hematologically, there may be normochromic normocytic anemia. Coming to nervous system, the patient complains with tremors. So before case also we saw some fine tremors in the patient. Okay. And muscle weakness, periodic palsy. Okay, reflexes will be, deep tendon reflexes will be elevated, which is hyperreflexia. Okay. Coming to eye, before that skin will be moist, whereas dry skin will be seen in hypo. Here it is moist skin. And pruritus, patient may be presenting to the OPD with itching. Okay, itching, hair thinning, alopecia, palmar erythema, and this is main complaint is pretrivial mixed edema. Pretibial mixed edema, it is present in hypothyroidism as well as here also. So you should rule out whether it is due to hypo or thyrotoxicosis. Oncolysis means nail this will be peeled off, the nail plate will be coming off. So on oncolysis, hyperpigmentation will be seen. Vitiligo may be present. Coming to genitourinary system, and patient may complain of amenorrhea or oligomenorrhea. Female patients, amenorrhea or oligomenorrhea. Menstrual disturbances will be there. Infertility may be seen, and gynecomastia in male patients. Okay, loss of libido, impotence, urinary frequency, and nocturia. Coming to eye signs are very important in thyroid case, thyrotoxicosis. So the patient may be coming with Stelvag sign, which is fixed eyes, still eyes. Okay, maybe dull rimpy sign, means there will be lid lag, means lid retraction. Okay, lid retraction, or the patient may present with Stelvag's dull rimpy sign and Von Graffi sign. Von Graffi sign is V, you remember U, upper lid lag, whereas Griffith is lower lid lag. Okay, Griffith is lower lid lag, whereas Von Graffi is upper lid lag. And we will have N froth sign, which is N froth means fullness. Okay, fullness of the lids. Okay, these are the main signs of the eye we should be remembering, okay, for our exam. So this is eye symptoms. And skin we had already seen, hyperpigmentation, vitiligo. Hair also we had seen. So what investigations you will do, how do you will proceed here? So you will first ask for CBP for looking any anemia, and you will ask for thyroid profile, right? Thyroid profile. And you will, so management is anti-thyroid drugs, right? And you will also do one radioactive scan, that is technetium 99 scan. Okay, and anti-thyroid drugs and USG thyroid you will do in investigations. You will do USG thyroid and technetium 99 scan. Anti-thyroid drugs, what are the anti-thyroid drugs? One is propylthiouracil, another one is methimazole and carbimazole. This acts against the organification. Okay, organification, so step. Okay, then PTU may cause hepatic failure, so it is only permitted to first trimester. If you give in second or third trimester, the fetus heart will fail, means a fetal heart failure may occur. So be careful while giving PTU. Okay, methimazole and carbimazole. So methimazole and carbimazole 5 to 10 mg you should be giving. The dose is 5 to 10 mg, and in older patients if they come, you will go with the this radioactive iodine therapy. If you are planning to give radioactive iodine, if the patient coming in pregnancy, coming with not pregnancy, coming with enlarged gland and all, so you are planning to give radioactive iodine, means tell the patient not to become pregnant within 12 to 6 to 12 6 to 12 months. Okay, 6 to 12 weeks. Okay, 6 to 12 weeks before giving the radioactive iodine, and plan after 12 weeks of giving radioactive iodine the pregnancy. Okay, so and stop anti-thyroid drugs before 4 days giving the radioactive iodine, and start after 4 days of radioactive iodine therapy. Okay, the anti-thyroid drugs. And we had already discussed eye signs, we had already discussed clinical features, we had already discussed investigations, we had already, now we are discussing the treatment. In this part we had already discussed anti-thyroid drugs, that propylthiouracil, carbimazole, methimazole 5 to 10 mg, and if in pregnancy we may confine to, if it is mild thyrotoxicosis, we may go with 2 mg, like that slight doses, and radioactive iodine. Okay, and another choice is subtotal thyroidectomy. Okay, subtotal thyroidectomy. So we have many thyroidectomies. One is hemithyroidectomy. Okay, one is total thyroidectomy. Okay, this is subtotal, leaving the capsule behind and removing the gland. So you should see the plane of dissection also, because in the thyroid the capsule will be lying between the true and false capsule. It is lying in between the upper and lower fascia splitting మధ్యలో ఉంటాయి కాబట్టి. So be careful. We will discuss this in surgery. Basically here only we have to know what procedures will be done in the thyroid. Okay, you should be careful, should not injure any thyroid arteries or anything there. Okay, okay guys, that's it for today. We had discussed thyrotoxicosis. So to become euthyroid, you are giving anti-thyroid drugs after 4 days of radioactive iodine. Okay, see, if it is severe thyrotoxicosis, you can't plan the surgery. Okay, so it should be euthyroid state to plan for the surgery, right? Okay, that's it guys. Thank you for listening to me carefully and patiently. Okay, let's discuss more classes. Okay, we will continue this. If you like, please share and subscribe.